Yeah, dear Chairman, ladies and gentlemen, I thank the organizers for inviting me, and it's a pleasure to be here. As you just heard, stroke occurs in 4 to 8% of the TAVR patients, but this is just the tip of the iceberg. Doing MRI assessment, we have learned that about 100% of the patients are affected by multiple silent brain infarcts, and we know that those silent infarcts increase the risk of future stroke, dementia, mortality, and cognitive decline. So attempts have been made to reduce the risk of silent infarcts, namely through the development of embolic protection system. But what is the clinical evidence we're having so far? We were one among the first to conduct a randomized study comparing TAVR using the Medtronic core valve prosthesis in the presence and absence of embolic protection. And in this study, 100 patients were randomized to TAVR in the absence or presence of embolic protection. And in this trial, we were able to show a 57% reduction in the volume of new ischemic brain lesions in the presence of the Claret montage device. So more evidence is coming from the Mistral C study conducted by Nick van Meegen. Also in this study, patients were randomized to TAVR in the presence or absence of the embolic protection system, the Sentinel system. In this study, 3 different valve types were used: the self-expandable core valve, the SAPIEN XT, and the SAPIEN 3. And in this study, they were able to show a numeric reduction in the volume of ischemic brain lesions, and also a better preservation of neurocognitive function in those that had TAVR in the presence of embolic protection. However, most of the evidence is generated by the Sentinel study that randomized 360 patients in a 2-to-1 fashion to TAVR in the presence or in the absence of the Sentinel embolic protection device. The safety cohort is formed by the 360 patients, predominantly by the 2/3 that were treated in the presence of the embolic protection device. And there's a nested imaging cohort. In those patients, an MRI was performed before and after the intervention to evaluate the volume of new ischemic brain lesions and compared to the control group that had TAVR in the absence of the embolic protection system. There were 2 endpoints: a safety endpoint, which was MACE, defined as all-cause mortality, stroke, and acute kidney injury class 3, and this was compared to performance goal that was historical. And secondly, there was the superiority efficacy endpoint, which was a reduction median total new lesion volume in the protected territories as determined by MRI at 2 to 7 days. So these are the procedural characteristics, and I just want to highlight a few things. In more than 99% of the patients, at least one filter was deployed, and in more than 94% of the device arm, 2 filters were in a proper anatomical position and maintained there throughout the procedure. The procedural time just increased a little bit, but there was this steep learning curve, and in addition, the fluoroscopy time just went up slightly, and this did not reach statistical significance if the device and safety arm were combined. Importantly, 4 different valve types were used. About 17% had the XT, 50% the SAPIEN 3, and about 28% the self-expandable core valve or core valve evolute R. So this is a primary safety endpoint. As you can see, the 30-day MACE rate in the device cohort was a lot lower than the historical performance goal. So this device is safe. And in addition, numerically, the MACE rate was lower in the device cohort as compared to the control group. What is specifically important is that numerically, in the patient that had TAVR in the presence of the Sentinel device, the stroke rate was numerically lower by about 40%. And this did not come at the cost of a vascular complication rate, just 1 vascular complication in 230 patients. So this is a primary efficacy endpoint. There is a numerical reduction in the MRI new lesion brain volume in the protected areas, but due to the variation of the measure, unfortunately, this did not reach the level of statistical significance. But throughout the study, we learned that were significant co-founders, for instance, baseline cerebral disease, and after adjusting in a post-hoc manner for those co-founders, there was a 49% reduction in the new lesion volume in the protected territories, and after adjustment, this is now significant, but as I said, a post-hoc analysis. Combining the evidence from those 3 studies and doing a meta-analysis from Sentinel, Clean TAVR, and Mistral C, and looking at cerebral new lesion volume on MRI, there's a significant reduction in this meta-analysis supporting the use of the Sentinel or the montage in reducing ischemic brain volume and reducing silent stroke. This is one of the most important findings from the Sentinel study. It shows you the evaluation of the histopathology. So in 99% of the patients, embolic material was found in the filters. So this means every patient that has a TAVR is at risk, independent of baseline disease, independent of the valve type you are using. And what is predominantly found is arterial wall tissue in combination with thrombus, valve tissue, calcification, foramen arterial, myocardium. So all of those things that are going to stay in the brain are not going to dissolve by itself. Importantly, 1 out of 4 patients had an average of 25 particles that were more than 0.5 millimeters in size, and you can imagine that those particles of such a size lead to permanent occlusion of cerebral vessels and with the consequence of cerebral damage. However, these are all surrogate parameters. Everybody's interested in the clinical results. So first, I would like to draw your attention to the control group. In the control group at 72 hours, we were seeing a stroke rate of 8.2%. And this, despite of the fact that 50% of the valves were self-expandable. So this means the stroke rates you are seeing, if you do a neurologic assessment before and after the TAVR in a routine fashion, is going to give you a true estimate of the amount of brain injury. So this is an important thing, and this is explaining, because of this routine assessment, we have a stroke rate is 8.2%. But if you use the Sentinel, you are able to reduce the stroke rates numerically on day 1 by 66%, day 2 by 50%, day 3 by more than 50%. So in combination, using the Sentinel during the procedure reduces the stroke rate by 63% at 72 hours, and it was significant in the post-hoc analysis. There's more evidence from a recent meta-analysis comparing different trials that use different embolic protection devices. But in summary, what came out, there's a 40% reduction in the risk of stroke or death with the use of embolic protection during the procedure. As a last clinical site, and I think Dr. Wörl is going to talk about this more in his talk, there's the ULM Experience that consisted of 802 all-comer patients, and I just would like to highlight one of the slides that in the propensity-matched analysis is comparing 280 patients that had the TAVR in the absence of the embolic protection system and 280 that had it in the presence of the embolic protection with multiple different valves that have been used. And as you can see, routine use of the Sentinel system reduces the risk of stroke at 7 days by 70% and the risk of death and stroke also by 70% in daily clinical practice. So in summary, the Sentinel embolic protection system is extremely safe. Its use in TAVR leads to a reduction in the volume of diffusion-weighted MRI positive brain lesions by about 45%, a potentially better preservation of neurocognitive function, and a potential reduction in clinical events, stroke, and in a composite of death and stroke. Given that every patient is at risk, independent of the valve type and of baseline disease, as you have seen from the histopathology data, and that even small lesions might have a deep impact, and that the cerebral protection system has been shown to be safe, it should be used in all TAVR cases from my point of view. Thank you.